Hi, my name is Marie. I'm a nursing practice consultant, and I will be talking to you about the updates on the hypoglycemia protocol and collective order. The work was done with our IPS, Loredana Talos. We'll present the changes to the protocol and the collective order, which applies to adult patients. Those changes come from the updated hypoglycemia in adults from Diabetes Canada. It aligns with international nomenclature for events as well as management of the episodes. So, first, an overview of the changes in the protocol. The protocol is applicable everywhere except the MGH and RVH intensive care units. It's applicable to ambulatory areas, dialysis, intensive care units for the coronary care, the neuro, as well as respiratory intensive care unit, as well as our acute care units and the CHSLD. We've made some clarifications. For most individuals, the target glycemia correction is 5 millimoles per liters. The definition of a hypoglycemia still remains below 4, but when we correct, we want to target more than 5. This is not a change from previously, but it's just highlighted more evidently. And as previous, for pregnant patients as well as islet cell transplant patients, we correct for a target of 4 millimoles per liters. We've added some instructions on patients that are receiving tube feedings. We wanted to make sure that there is instructions on how to administer enteric carbohydrates for patients that have tube feedings and instructions on how to handle the post-event snack. An important change is the determination of severity of a hypoglycemic episode, and the amount of glucose to administer is now based on clinical symptoms, regardless of the capillary blood glucose level. We still need a hypoglycemia, so we still need a blood glucose that is less than 4. However, a higher severity event will require more glucose to be given, regardless of that number. We have the definitions here. So for a patient that is asymptomatic or has physical symptoms but no neurological symptoms, they would be classified as a level 1 event. If they have neural symptoms but no altered mental status, it's a level 3. And a patient with significant impairment in their mental state would be classified as a level 3, regardless of the blood sugar that's below 4. When in doubt, we advise nurses to choose level 3. Um, in the protocol, you will see the equivalent of oral glucose to give. So for an episode level 3, we do want to give 20 grams of oral carbohydrates or enteric carbohydrates. And level 2 or 1, we would give the 15. So this is not a change. We do highlight that patients that are taking Acarbose, we must use glucose tablets. And if the glucose tablets are not available, you can give milk or honey to treat the hypoglycemia. And that's because Acarbose is a medication that is used to treat type 2 diabetes. It slows the digestion of complex carbohydrates. It helps to control the blood sugar levels after a meal. It blocks an enzyme that breaks down complex carbohydrates into simple sugars. And by blocking this enzyme, the glucose absorption is slower and it prevents the rapid spikes in blood sugars after a meal, which means that when we're trying to treat an hypoglycemia event, we do need to use simple sugars such as glucose tablets in order to not depend on the enzyme that's blocked by Acarbose. So example of some simple sugars to be used in patients taking this medication is glucose tabs, lactose, glucose and fructose found in honey. But we do not use sucrose that would be found um, in a fruit or a juice. Another important change is if your patient does not have the ability to take oral glucose, we will treat the episode with dextrose IV as the first step or as um, the first line of treatment. We will give the 25 grams IV in one step rather than giving 15 grams and then 10 grams afterwards. We give the 25 all at once. If you do have a patient that is not able to take oral or enteric carbohydrates and you do not have venous access, you can give glucagon intranasal. You will find it in the UBEC. Some areas might also have the subcutaneous or intramuscular glucagon. However, it's reserved for patients that are younger than 4 years old. So on the adult side, we will privilege the intranasal only if you cannot give the dextrose IV. The protocol also has a reminder on how to give the glucagon intranasal. Another change is we give more proteins and less carbohydrates in the snack after an event. We are now giving cheese along with soda crackers. We know that the cheese and the snacks tend to disappear quickly on units. You can also give some Glucerna or diabetic resource as well. Okay. And for patients that are getting enteric feeding solutions, you will need to do a bit of calculations to see how much solution you need to give if your patient's not having a snack or a meal right away. The protocol will have an example on how to do that rule of three to see how much um, solution to give as a bolus. Now, as a reminder, you would give a bolus of feeding solution only if your patient's feeding is not supposed to start in the next 60 minutes. We've also updated the documentation form. So in the back of the glucose monitoring, you have space for 4 events. We have changed it so that it reflects the new evaluation of the level of hypoglycemia, as well as the treatment has more room for you to customize what you've given. Also, a reminder to decrease the next dose of insulin subcutaneous. Um, After an episode, you do have to follow the prescription that's in your patient's chart. You are expected to contact the prescriber if your patient has symptoms despite a blood glucose that's more than 4, if the hypoglycemia persists after 2 treatments, and at the end of the episode. There's an algorithm that's very small on the screen, but I break it down in details in the next few slides to help you walk through the algorithm. So the first step, okay, is your patient having symptoms of hypoglycemia. If they do, you will measure your capillary glucose. If you have a level of more than 4 and your patient has symptoms, you do need to look for other cause. Right? So you would adjust your IV insulin perfusion if you have one, and contact the physician to work up what's the cause of the symptoms. If you found a blood glucose level that's less than 4 and your patient had already is not showing these symptoms, you will adjust your insulin infusion, and then you need to evaluate the level of hypoglycemia. Once you evaluated your patient's level of hypoglycemia, you also need to evaluate if they're capable of taking carbohydrates by mouth or by tube. If your patient is NPO or they cannot take it because of their altered mental state, you will choose parenteral glucose. Your first choice is always dextrose IV. And if you don't have an IV access and you can't get it, then you can give the glucagon intranasal that you will find in your UBEC. Now, just a reminder, if you're treating the episode with parenteral glucose, um, you will give the full dose. You don't need to give more if it's a severe event. However, if your patient is able to take PO, you will adjust the amount of carbohydrates you're going to give depending on the level of hypoglycemia. Once you've treated the episode, you do need to measure the blood glucose 15 minutes after the treatment. Okay. If the blood glucose is more than 5, or if your patient is pregnant or they have an islet cell transplant, if the glucose is more than 4, you move on to reassessing your patient to make sure that there's no more symptoms. If there are symptoms still present with the blood glucose that's been corrected, you will advise your physician to look for another cause. If the symptoms are all gone, you will go ahead and move on to the next step, which is the snack and measuring your blood glucose every 30 minutes twice. If any of the times that you measure your blood glucose, the level is too low, so if it's less than 4.9 or 3.9 if you have a pregnant woman or a patient with islet cell transplant, you will need to assess if you can give another treatment. If you've already given 2 treatments, it's time to call your physician. But if you haven't, you go ahead and you get a second treatment. When it's time to give your snack, if your patient is NPO, you do want to inform the treating team. They might want to do some adjustments to factor in that your patient is not getting a snack. But if they are able to take oral, so either feeding tube or with a snack, and the meal is not coming in less than 60 minutes, you do need to provide a snack to avoid another crash. Once everything is done, you want to make sure that you document your episode. If you're in an ambulatory sector or in an area where your patient is not getting normal blood glucose checks, you will do it in a progress note. Don't forget to adjust the next dose of insulin subcutaneous according to the prescription and to inform the prescriber of the event. Just a quick reminder for CPs or CPNs, you do need the support from a reference nurse. Okay, a patient that's showing signs of hypoglycemia requires an assessment, and if you are going to initiate the collective order, you do need to have a reference nurse to assist you with that decision making. So at any time when even if you find your patient that has asymptomatic hypoglycemia, you will need to speak to your reference nurse to walk you through the steps. Okay. In terms of licensed practical nurses, um, the patient is also considered not stable, so she will need to work with the registered nurse for um, taking the vital signs, taking blood sugars, giving oral glucose, or the intranasal glucagon, subcutaneous or intramuscular, as well as the snack. However, she will not be able to adjust the IV insulin infusion or evaluate the level of hypoglycemia or evaluate the patient's ability to take oral or enteric glucose, and she will not be able to give the dextrose IV. Okay, so as a summary, what's new in this protocol is the introduction of glucagon for patients without intravenous access, the blood glucose correction plan for patients with enteric carbohydrates. The severity of hypoglycemic episode is defined with symptoms, not just the blood sugar, and we want to give more proteins for the snack. You are expected to contact the medical team in the following situations. So, if your patient shows symptoms of hypoglycemia despite a blood glucose level more than 4, if there's persistent hypoglycemia despite 2 treatments, and you do want to notify the team after an episode has responded to treatment. We're now going to practice with a case. Okay, so I'm introducing you to Mr. Edward Jones that was admitted 15 days ago for general deterioration. He's developed persistent diarrhea, some nausea, some vomiting, and abdominal pain. He has a dub-off feeding tube and he's receiving isosource 1.5. He is strictly NPO And his medications include metformin, morphine, as well as an insulin correction scale that has Lactose as well as Novorapid. And his blood sugar level this morning was 5.7. It is now lunchtime, uh, and you enter the room, and Mr. Jones is lethargic. He's sweating and shaking. So, according to you, what could be going on? We're obviously having a talk about hypoglycemia, so you're going to think, maybe I need to check his sugar. So, what do you do? So, you do check his sugar, and the level is 3. Okay. So, what level of hypoglycemia this refers to, um, and what do you do? So it is a level 3, okay, and you would want to treat it with 20 grams of enteric glucose for him because he's and strictly NPO, and you will have to choose whether you're going to use the glucose tabs or packs of sugar with water or juice. Okay, he does have a dub-off feeding tube, which means that it has a tendency to block. So you would want to try something that has the least amount of residue or the best diluted solution. Okay. If ever for some reason, because he's NPO and you're not comfortable giving it in a dub off, you would go ahead and activate the collective order. You could give him some dextrose, 25 grams IV, or the glucagon intranasal. The glucagon subcutaneous or intramuscular is really reserved for exceptional cases and mostly for the children's. So you've given your carbohydrates. When's the next time you're supposed to check his blood sugar? So you're supposed to check it in 15 minutes. Okay, so you check it and it's now 3.6. So what's your next step? Okay. So you do need to evaluate his symptoms. He's still sweating, but he doesn't have any tremors and he's not lethargic anymore. He doesn't shake anymore. The target for Mr. Jones, a adequate correction would be more than 5, and we're at 3.6. So what will be our next step? Our next step is going to be to give another round of glucose. And based on his symptoms, you would give 15 grams of glucose. Okay. And when do you measure again his glucose level? It would be after another 15 minutes. Okay. So you're now another 15 minutes later, it's now 12:30. You've treated him twice, once with 20 grams of glucose and once with 15 grams of glucose, and his blood sugar is now 5.5. What's your next step? Your next step is to make sure that you assess his symptoms. Okay, we're in our target correction. We need to make sure he has no more symptoms. They're all gone. Okay, so when would be the next check for his glucose? Well, according to the algorithm, we would do um, a check in 30 minutes and another one after that 30 minutes as well. And now my question to you is, what do you do to avoid another hypoglycemic episode for Mr. Jones that is actually NPO? Okay, but he's getting some solution. Okay, so you would have to adjust his give him a bolus of feeding solution. Okay. So when you look at the packaging for Isosource, you see that it's 17.6 grams of carbohydrates per 100 mLs, and your target is to give it 15 grams of carbohydrates. So you need to do your rule of 3. Okay, you do 15 grams times 100 mLs, and you divide that by 17.6 grams, and it would give you 85 milliliters of feeding solution to provide him with 15 grams of glucose. So this is a bolus you would have to give him only if he doesn't start his feeding tube in the next 60 minutes. Okay, so you do have to look at your orders for your feeding solution. If he's due to start his regular bolus, you go ahead and you give the bolus. But if he's not receiving anything until, let's say, 5 o'clock tonight, then you would have to give him 85 milliliters. Okay, and you do round down for 85. Okay, your next step is to also document. Okay, so this is an example of how this would be documented on the new form. Okay, so we do have at noon his blood sugar was 3. Your assessment classified his level of hypoglycemia as a level 3. So you gave him 20 grams of glucose per tube. It's not time for snack yet. Okay. 15 minutes after you checked, his sugar was 3.6. You assess his symptoms. He was still shaking, but no other symptoms. So his level of hypoglycemia is down to 1, which you will correct because it's less than 5. You're going to correct it with 15 grams of glucose per tube again. Okay. You check the sugar at 12:30. It's 5.5. You're in the target correction zone. He has no symptoms, so you don't need to treat, but you need to give him a snack because he didn't have any bolus or feeding solution scheduled in the next 60 minutes. And then you have your 2 next checks that you have to do at 30-minute intervals. Okay. If you still are using the old form, you're going to have to tweak it a little bit to reflect the same type of information. Okay. Don't forget, Mr. Jones is also getting some insulin in a sliding scale. So, because his hypoglycemia event happened at lunchtime, you do need to adjust his insulin that you're going to give him um, after the episode is over because you've now corrected it. Okay, and you have to you still check the glucose level, the blood sugar, but you're going to give him insulin as if he was in the 0 to 4 range. So you would, instead of giving him 6 units, you would give him 2 units of insulin of Novorapid at lunchtime. Okay. If you have any questions, please reach out to your educator. They will be able to answer them or reach out to me if needed.